Okay, we'll get started. I can't get the AirPlay to work, so we're just off of this. It's recording. It's just not. I can't draw it. What? I know, but I don't know. The problem is this. So here's the problem. It, Macs don't allow you to screen record when you AirPlay. So if I AirPlay to a Mac, I can't record what you're seeing, everything. It doesn't work that way. So I'm trying to figure out a different way to get it going where I don't have to use AirPlay because I'm using it on a PC, which is not the best all the time. That's why I'm having issues. So if I can get it working over a break, we'll start up again. But for now, so yesterday or last week we did asthma and a little bit of the introduction to the breathing. We talked about PFTs, FEV 1%, what that should be at. What's the number for FEV 1%? What's the cutoff? Magic number to remember for FEV1 is 80%. 80%. Okay, so above 80, you're okay. When you start getting below, you start getting problems. So we talked about asthma. So asthma, chronic bronchitis, and emphysema are all considered COPD, the obstructive pulmonary diseases. The key thing is the bronchitis and emphysema are permanent. They're not reversible. Asthma is reversible. The other ones aren't. So again, COPD is intentionally imprecise term, either chronic bronchitis or emphysema, that may lead to the development of a fixed airway obstruction. So that's why it's not reversible. The obstruction may be partially reversible, but you're not going to treat them and cure them totally all the time. Now, this is an important thing to deal with in medicine when it comes to like treatments. The etiology of why you get bronchitis or why you get emphysema is different, but the treatment for both diseases are the same. So whether they have emphysema or bronchitis, it doesn't matter. If they have it and they're coming with COPD, you treat the COPD. The underlying cause doesn't matter, unless it's what? A common underlying cause for bronchitis and emphysema. Smoking. Yes, stop smoking. You got to do that. It's a common one for both. But a couple of things also to keep straight between bronchitis and emphysema. Bronchitis is a disease of the airway, whereas emphysema is a disease of the lung tissue itself. So in emphysema, the issue is all the alveoli, they lose their recoil and they just get wide open. There's no recoil of the alveoli. So the problem with emphysema is the tissue itself. The alveoli don't work, the recoil is gone. And in chronic bronchitis, the problem is the bronchial tree and all the obstruction that occurs with that. And we'll go through them as we go through. This is very important. You have to understand the criteria for diagnosis. So chronic bronchitis means a productive cough for 3 months of the year, 2 consecutive years. So every year from October to December, they're going to have this chronic bronchitis flare up. They start getting all this coughing, productive coughing, so they're producing sputum or mucus. That's what a productive cough means. If it's non-productive, it's a dry, hacking cough. They can't bring up any mucus. They're going to get a sore throat later on. So as another example, when you guys are doing your PD exams and you're going through writing your notes, one of the big things is progression of disease. What happened first, what happened second, what happened third. As an example, let's say someone has a sore throat and postnasal drip from that sore throat, and then they develop the cough. That's the sore throat caused the coughing problem. But let's say, no, my coughing started first, it's been this dry hacking cough, and then I got a sore throat. Well, the sore throat was probably just from coughing like crazy all the time. So you see how the progression, what happened first, what happened second, what happened third, will clue you in what's going on. So chronic bronchitis, 3 months of the year where they're affected for 2 consecutive years, and then you can diagnose them as having chronic bronchitis. Cigarette smoking is going to be a big one, of course. Inflammation of the smaller bronchioles, and that's the principal site of the airway obstruction. It's in those small bronchioles that branch out into the alveoli, little bunches, little grapes. That's where it's happening. Emphysema, irreversible enlargement of the air spaces accompanied by destruction of the walls. So it's a tissue problem because you're losing your elastic properties of the alveoli. What prevents the alveoli from collapsing on itself? Surfactant. Very good, surfactant. But we also want them to expand so you can get bigger and then recoil to get the air out as well. So we lose the recoil. No mucus production or cough with emphysema. They don't get it. But because we're losing alveolar surface area, remember the big thing about the lungs is a big surface area for diffusion. Well, now because of the emphysema destroying the alveolar walls, we're losing a lot of that surface area. So because you're losing your area, your surface area for diffusion, you're at risk of getting progressive hypoxia because diffusion area is reduced, and resulting dyspnea because of lack of oxygen. You're getting short of breath, you need more air coming in. Emphysema is not always caused by cigarette smoking. There is a genetic component, we'll get to that in a little bit, but for the most part, it's always due to smoking. And then here's a little cheat sheet to go back and forth between bronchitis and emphysema when you're reviewing later on. So a little bit etiology and epidemiology. Obviously 15 million people in the United States. 2/3 of the cases of COPD are chronic bronchitis, and the last little bit is emphysema. So bronchitis is more common than emphysema. Incidence, prevalence, mortality rates increase with age, higher in men, whites, and people with low socioeconomic status. Obviously, cigarette smoking is the principal cause of these COPD illnesses. Here is the genetic part. This alpha-1 protease or alpha-1 antitrypsin, that is a genetic risk factor for emphysema. So if you see this anywhere, this is the genetic cause for the emphysema. So these people may never have smoked in their life, but they have this genetic defect, and they develop emphysema later in life. So I always say you don't want to have it to the point where you tell your patient, listen, just keep smoking if it makes you happy, because it's not going to change anything. That's the worst thing you can say, but if they have years and years of smoking and they don't want to stop, I mean, they want to be happy for the last little bit, but but yes, get them to stop smoking. But what I say is, like, if the cancer is so far advanced, stopping smoking is not going to help them. It's just going to cause them more anxiety and stress. Stopping smoking, just continue on. But in most cases, yes, stop the smoking, you'll be fine. Okay, so chronic bronchitis, chronic injury and narrowing. So chronic injury, we talked about chronic injury before. We don't like it. Our body's going to heal differently when you have this chronic injury going on. Get inflammation of the airways, hypertrophy of large airway mucus glands. That's going to give you all that mucus and sputum production that you get with this chronic bronchitis patients. Due to chronic inflammation, those normal ciliated pseudostratified columnar cells, which have the cilia, which we talked about, beats those pathogens in the mucus up so you can clear it and get it out, is replaced with patchy squamous metaplasia. So our cilia is gone, and that's why people with chronic bronchitis are always, they're always doing that because they can't clear it out themselves, so they have to do it manually, and they keep making this all the time. That's chronic bronchitis. They're trying to get that stuff out. Now, if they're getting over being sick, people may have that when they're sick, but these people will do it every day. Bronchial smooth muscle hypertrophy. When that smooth muscle starts to hypertrophy, what happens to the size of the lumen? Gets narrower and smaller, less flow. You're causing an obstruction with all the swelling that you're causing. Bronchioles are also infiltrated with inflammatory cells and get distorted. Increased areas of low VQ ratios with chronic bronchitis. and emphysema, or chronic bronchitis. Responsible for resting hypoxemia. So low VQ ratio. Is the problem with ventilation or is it perfusion? Ventilation. This is an airway obstruction problem, so we know ventilation is a problem. So ventilation starts to go down, therefore the VQ ratio goes down and down and down. You'll see low VQs with chronic bronchitis. Also, thickened walls. It reduces the size of the lumen, which we already talked about, decrease the amount of air. So we already discussed all that. Everyone following so far with chronic bronchitis? Okay, and again, this is what it looks like. Smooth muscles and hypertrophy. All the mucus glands get bigger, starts secreting a lot of mucus going on. You'll see what happens with this mucus in a little bit and why it's a big problem. They cause mucus plugs, where, if you ever, what are you listening for when you hear crackles in the lungs, sort of also, like popping noises? Some of it is, could be pulmonary edema, but think about it. If you're breathing in and out, if you have they're essentially like snot bubbles, and you're trying to pop those when you breathe in and out. So all those popping that you're hearing, crackles, can be mucus plugs that you're popping by breathing in and out. That could be another form of what you hear. So this is what happens. When you breathe in, the mucus plug, which is this little black thing right there, allows the air to come down, and the air can get into the alveoli. But during expiration, the air should come back up, but the mucus kind of falls into the airway. Air can't get back up. So air starts to collect in the alveoli, and you can see with chronic bronchitis, the alveoli shape gets bigger. They start to expand and get big because this is trapped air. You can breathe it in, but you can't get it out. This is the obstruction. And when you hear the sound going past all this, this is the wheezing and the sounds that you hear. Remember, it's turbulent flow. In the heart, okay, we just have a little bit left to go, and then we'll be done for the material that's going to be on Friday's exam. Tomorrow, we'll have, tomorrow, some case studies to go over, some derm case studies, poem case studies, and a Kahoot for the review. Okay? So the last little bit, we're going to go over is just the last other little pulmonary, so I got the thing working. So tuberculosis, 2 million people die from TB, 10.4 are affected. Third of the world population has TB, so one of the things, again, which is why anyone coming in with some weird, non-contributory symptoms, I have fever, night sweats, I'm losing weight, I don't feel good, and you ask them, where'd you go? I was just in a different country for a little bit, I just came back. That's where travel history is important. Where were you going and stuff like that. In U.S., 9,200 cases in 2016. It's gotten better the last 10 years. But it has reemerged as a major health concern, especially those with HIV. They get bacterial resistance to medications with TB history. Increased, obviously, international travel. Is there a reason for the increase in TB? And a lot of homeless people and drug abusers. TB is rampant in those populations as well. So Mycobacterium tuberculosis is the bug that causes tuberculosis. Mycobacterium, so it is a fungi as well as a normal bacteria. Rod shape, acid-fast bacilli, just remember that. I don't know if you got there in micro yet, but you did already perfect. So remember that one because that's a test you have to do to see if they have TB or not. It is droplet transmission, so it's airborne. So you have to be careful for airborne precautions. If you worked in an emergency room, you'll know they have a little isolation rooms that have different types of pressure so that everything stays in the room and doesn't spread. If you know going into rooms, especially when you get onto clinicals, and if there's a sign on the door that says wear PPE, and there's a yellow gown and the mask and all that stuff outside the door, put it on, all of it, and go in the room, see the patient. Droplets can remain airborne for minutes to hours after expectoration. So just when they start coughing, because they left the room, those droplets can still be in the air or on the ground or on a table or anything. The transmission of TB is influenced by a couple of properties. The number of bacilli they just actually have in those droplets. So the more bacteria, the more availability you have for transmission because you have more of them. The virulence of the bacilli, how alive is it? How active is the bacilli? Will it spread? The degree of ventilation, how well is the room ventilated? How well do you breathe? And so forth. And occasions of aerosolization, so how often are they coughing in the air? Are they wearing a mask to trap it all inside them or whatever? So these are 4 things that can influence transmission of tuberculosis. So what is going on? The majority of these bacilli are trapped in the upper parts of the airways, where the mucus-secreting goblet cells exist. So bacilli are trapped in the upper part of the airways. The cilia of the surface cells beat the mucus and entrap particles up, which is what normally should happen. This prevents infection in most people who have been exposed to tuberculosis. So being exposed versus being infected are 2 different things. You could be exposed to everything, but you're not infected by it because when you have a healthy immune system or those other things that influence transmission of a disease. Bacilli in droplets that bypass our mucociliary system and reach the alveoli are quickly surrounded and engulfed by macrophages. So any bacilli that do happen to get through the upper bronchus, those upper airways, and gets into the alveolus are quickly brought up and enveloped and taken out. So when this phagocytosis occurs, there's 2 things that can happen. 1, you control the infection, and this is called latent tuberculosis, where you have the bacilli, but they are controlled in the alveoli and they're not causing any problems. But it's latent. What does latent mean? Delayed. So these patients who have latent tuberculosis, later on you'll see how they can develop tuberculosis later. Or progress right to active disease, and that's called primary progressive tuberculosis. You've been exposed the first time and then you got sick, yes?
So like the macrophages like eat it or whatever?
Well, yeah. Well, yep, I'll show you what they call GON complexes, G-H-O-N. So if you ever heard of that before, that's what we're talking about in a second. So T cells are recruited during the TB exposure, cell-mediated immunity. Patient is now sensitized to TB once they've been exposed to it. So PPD antigens are from killed tuberculosis. And if you've been exposed to TB in the past, your body now knows what to do to it because we've already had our B cells memorize the TB to make antibodies and all that delayed hypersensitivity reaction. So now if you give someone a PPD which has dead TB in it, your body's like, hey, this is tuberculosis. I know what to do to kill it. Let's go to this area, cause swelling, and kill off the TB. But what happens is you get that induration, that raised mark from all the white blood cells going into that area to kill off the TB. That means if you have it pop open and get up and raised, that means that you've been exposed to TB at some point in your life. Now you're reactive to it. The next thing they have to do, if you ever had a positive PPD, they have you go for a chest x-ray, right? And what are they looking for? These GON complexes. These GON complexes are formed when the macrophages envelop the bacilli. They try to isolate it and quarantine them. And they form these GON complexes. And this is what they look like, these little things up there. Here is one. Let me change color. Okay, They're just these little dots, these little complexes that shouldn't be there, that should not have any tissue right there in that direction. So that's one of them. Why do I get all these Teams calls through here? Okay. Okay, so those are the GON complexes that you would see on a chest x-ray of someone who's been exposed to TB in the past. What these little things are inside there is the acid-fast bacilli. They're just waiting. They're dormant. When those things break, you get latent TB. Okay, so in a person with an intact immune system, healthy people, so no extreme ages. Whenever we say immune system being intact, we're not talking about babies, we're not talking about the elderly, we're not talking about immunocompromised people, HIV, AIDS, and so forth. So what happens is we get the formation of granulomas around the organisms. This is what we're talking about now, is how do we form those GON complexes that show up on X-ray. So these nodular type lesions, they show up little nodules in the lungs, limit replication and the spread of the bacteria. So we encapsulate it, we're trying to wall it off so it can't go anywhere else. Macrophages are then destroyed, producing a necrotic center. By 2 to 3 weeks, the necrotic environment resembles soft cheese, and we get a caseous necrosis. That's going back to lecture 1 when we talked about necrosis and all different types, liquefactive, coagulative. Here's this one, caseous necrosis. Further growth is restricted and latency develops. So again, we're trying to quarantine this bacilli so it doesn't spread anywhere else. Further lesions undergo fibrosis and calcification. Okay, now that they're calcified, that's why they show up on X-ray, because they have calcium in them and it shows up on X-ray. So once that happens and we've calcified them, we've controlled the infection, so all the bacilli are now dormant and in these healed lesions that are called GON complexes. Yes?
Will you always have those GON complexes like after you've been exposed to TB? Like, will they always be there? Will they eventually go?
Depends on, I think, if you actually got, so in order to get a GON complex, the bacilli normally resides up in the upper bronchioles in normal healthy people. But if it did get through and did get up into the alveoli and the apices, then eventually you will get these little GON complexes. And that's why anyone who has positive PPD, they have to get a chest x-ray right afterwards to see if they have GON complexes, which means that they have a dormant TB in them. You have a question? Okay. So again, the GON complex means you were already exposed, you had the bacilli in the alveoli, and we're trying to quarantine it off and isolate it. So you can see here is that caseous necrosis, all that Swiss cheese looking thing. And then here are your GON complexes. You can see how well defined those are. Okay, macrophages come in there, then they start to die off. That's why it looks necrotic compared to the other tissue around it. Macrophages all left. Now we have a nice solid GON complex that won't go anywhere. Yes?
At this point, is it still contagious?
We'll get to that in a minute, but it is what it is. Right now we're walled off. If these things break, then all that bacilli inside then will spread out. So as long as you have a GON complex, then you are relatively stable. Yes?
Is this just for latent tuberculosis? This
Yes.
isn't for primary?
Not for primary. Yes?
So if you have a positive PPD test but they don't find that, was that just like a false positive?
It could be, yeah. Also, if you were from a different country and they have the TB test over here, you can't do a PPD either because you will be positive every single time. Doesn't mean you have it. It's just that because of the way that they give you the vaccine, you will come positive every single time on a PPD. So here is in people with less effective immune systems, this is where we get that primary tuberculosis now. So this bacilli never undergoes that GON complex. They get weak, GON complexes break, and they can't be walled off. You get necrotic tissue, liquefaction all starts to develop with primary progressive tuberculosis. If they're immunocompromised, the semi-liquid necrotic material can then drain into a bronchus and nearby blood vessel. And when that happens, you can get an air-filled cavity at the original site called incavitation. These droplets can then be coughed up from the bronchus and infect other people. So when this little necrotic stuff starts oozing out and spreading back into the lungs, you can cough that stuff out. TB can spread also to blood vessels. This is called extrapulmonary tuberculosis. Bacilli can also drain into your lymph system, collecting your tracheobronchial lymph nodes in the affected lung, forming new caseous granulomas as well. So this bacilli is not good stuff to have in your body. The extrapulmonary tuberculosis is usually within the person itself. You're not going to spread that to someone else. But the TB got into the bloodstream, and now it's extrapulmonary because it's spread to the blood. So here's your cavitation right there. Lung mass is just gone because it got dissolved from necrosis from the bacilli. So the TB can spread to other organs. This is the extrapulmonary tuberculosis. It goes in the bloodstream. Disseminated or miliary tuberculosis. It can get to lymphatics. It can get to the pleura. If it gets to the bones and joints, it's called Pott's disease, which is tuberculosis affecting the joints. And your meninges as well, yes.
So cavitation is only going to occur in immunocompromised people?
Well, most immunocompromised people are going to get TB. Most healthy people won't get it to that form because their body can fight it off. But it's when they can't, it's just going to keep replicating and dividing and causing further necrosis of that cavitary lesion and getting bigger and bigger. So here's a good summary slide talking about the different stages of tuberculosis. You have your early infection, early primary progressive, and late primary, which are the active diseases, and then your latent, which is when you get the GON complexes and they're just sitting there waiting. Factors for disease progression. Co-infection with HIV is the most notable cause. So they can't fight off the infection and they die from tuberculosis, not from the HIV/AIDS. It's the tuberculosis that killed them, or the pneumonia that killed them. Uncontrolled diabetes, sepsis, renal failure, these are all things that can lead to progression of tuberculosis. Here is a summary kind of talking about what actually percentage of you actually getting TB is. So if you've been exposed to TB, 70 to 90% of you will not be infected with it. Okay, if you worked in a hospital, you've probably been exposed at some point to it, just from floating around. We try and minimize that, but again, the number of bacilli in the droplets matters, and if you don't have enough of it, it won't cause the injury going on. But 10 to 20, 30% of the people will become infected with TB. Of the 10 to 30% of the people who were infected with TB, 90% will remain dormant, never develop tuberculosis, and they are not infectious. So of, let's say, 100 people, 10 people got sick with TB. Of those 10, 9 of them will never have active TB. It'll just be dormant in their body. So out of 100, only one person actually gets TB. Look at it that way. In active TB, 5 to 10% will develop it within 2 years. Some more will happen many years later. That's that latent tuberculosis. And again, if you treat tuberculosis, you can be cured with it. There's a whole slew of antibiotics you got to take. I think it's, the mnemonic is, that's rifampin and a bunch of others. It's like 4 different drugs you got to give them. It's a whole mnemonic. You'll learn with Dr. Wood in Pulm when you start that up. And in Pulm, normal pulmonary CMS, treatment for TB, you go through all that. I think it's RIPES, R-I-P-E-S. Yes?
Is there treatment for dormant TB, or do you just leave it?
Just leave it. I think it's like rifampin, isoniazid, nitrimazole, erythromycin, and then streptomycin, I think. I don't know. But remember these stupid mnemonics, they help. Primary disease exists subclinically. What does subclinically mean? They don't even have any issues, there's no presenting symptoms. Nothing that rises to the level where I have a fever now, I have all this cough now, whatever the problem is. So again, they're virtually asymptomatic during all that latent phase. They may have a low-grade fever. Night sweats is a big one. That's why, what's the first system you always do in your ROS? Why? If they have TB, guess what? Stop your exam, put them in a room, and then start over again with proper precautions. But if you're like general exam, you have any night sweats, fever? Yeah, I got night sweats and fever. Okay, were you in a different country? Yeah, I just got back 2 days ago from wherever. Okay, why don't you go put a mask on? I'm gonna go out, put stuff on, and I'll come back and see you. You have to ask those questions first, again, to rule out any type of infection. You have to worry about yourself too. Keep yourself safe. So these symptoms down there are pretty, could be anything, right? But the night sweats is a big one part of it. But all those other symptoms, that could be just a fever. That could be like the flu. So, okay, moving on to pulmonary hypertension, which is core pulmonale diseases dealing with the lung itself. Signs and symptoms of core pulmonale, pulmonary hypertension: dyspnea, chest pain, syncope, edema, fatigue, and some cyanosis as well. So this is going to be a problem with the lungs itself, the lung vessels, with pulmonary hypertension anyway. So core pulmonale is that umbrella term involving the pulmonary vasculature. That's what core pulmonale is meaning. So pulmonary hypertension is an example of a blood vessel problem dealing with the lungs itself. Seen with underlying diseases, here's your IPF, COPD, sleep apnea can also cause pulmonary hypertension. Pulmonary hypertension, again, is just relatively rare as a disease. Not many people get it, but if you don't treat it, they're going to get decompensated right-sided heart failure. They're going to lead to right-sided heart failure because the pulmonary hypertension is causing a huge afterload on the right ventricle. Right-sided pressures are a lot lower than the left. They don't like very big changes. When you start increasing afterload, that right ventricle is going to get stressed out and it could potentially fail. Normal pulmonary pressure is 14 at rest. Remember, that's looking at your systolic and diastolic as it goes through. So pulmonary hypertension is sustained mean pulmonary artery pressure greater than 25 at rest or greater than 30 with exercise. Big number of cases, women between 20 and 40. Okay. So again, I'm pointing out women in that age, because pulmonary hypertension, again, if that comes up as a question, that's the type of patient that's going to have that disease. When you guys are studying, especially like with like pharm and PD, as you're putting things together, and you're looking at diseases, think about, okay, what would a patient look like if they had this disease? And that's why clinical year helps you guys, because you're actually seeing these things. That's why I joke, go to Disney and just watch people, because you'll point out a lot of things just by watching and observing people. The first thing you do when you walk into a room, you're observing your patient to see how are they sitting, are they looking like they're in distress or not. You know, I know you say, hi, I'm Jonathan Kaplan, I'm a PM, to take care of you today, but look at your patient and see what they're doing. Like, how are they sitting? How are they acting? Okay, another thing with pulmonary hypertension, with the right side of the lung, right side chamber is enlarged because of the volume overload, the pressure overload, and they can get some tricuspid valve regurg in this one. Another thing with pulmonary arterial hypertension, the PAH, right here, this plexiform lesion, whenever you hear the word plexiform lesion, think pulmonary hypertension. Okay, this is an advanced form of pulmonary hypertension, but if you see plexiform lesions on an exam question, think it's going to be pulmonary hypertension. At early stages, it's still a little bit reversible, but as you get to further problems with the pulmonary hypertension and you start getting these plexiform lesions, at that point it's irreversible. Before the plexiform lesion, now you're getting some, structure derangement going on. That takes a lot of time for that to happen. It won't reverse itself when they start happening, so start thinking that way. So plexiform lesions, pulmonary hypertension. That's what we're talking about here. Plexiform lesions from the remodeled pulmonary arteries. Okay. So what's going on with these patients? Pulmonary vascular fibrosis and thrombosis. So the tissue of the lungs is affected right now. Not going to work as well. We get remodeling, leading to decreased compliance, so you get very stiff lungs. This stiff lung resulted in increase in right ventricular afterload. We're pushing against these stiff pulmonary arteries, so the pressure goes up. This increased pulmonary vascular resistance leads to increased pulmonary artery pressure. You start reducing the flow back into the left side of the heart. So if we're reducing the preload on the left side because it can't get through the pulmonary system, your cardiac output is going to be reduced in those patients. So what do we do to compensate? Increase the heart rate to increase cardiac output. So now the heart doesn't really fill as well because we're increasing our heart rate. Remember, as we increase our heart rate, the filling goes down. There's less time to fill, which leads to a decreased stroke volume, which leads to further cardiac output issues. So it's like a vicious cycle that pulmonary hypertension causes. The cycle will repeat itself over and over again, leading to worsening and worsening pulmonary artery hypertension. So eventually the heart can't pump hard enough as the pressure in the lung increases. You get hypoxia, right atrial and right ventricular hypertrophy form. And that's why your cardiac silhouette gets wider, because the right ventricle is getting bigger. So that cardiac silhouette gets bigger on X-ray. Decreased oxygenation because of the congestion going through the lungs. And the big thing is, and they're not really here much, but you can see the constriction going on in these pulmonary arteries. Constriction leading to higher pressure in the system, higher afterload placed on that right ventricle, leading to heart failure to occur. Okay, right ventricular enlargement, secondary to a lung disorder. Okay, remember the most common cause of right-sided failure is what? Left-sided, but now we're talking about the other causes. We mentioned them briefly in the heart section, but now we're getting to them now. So right ventricular failure is going to follow, results from a disorder of the lung or the vasculature. It does not refer to right ventricular enlargement due to LV failure, heart disorder, or valvular disorder. What valvular disorder will cause right-sided heart failure? Mitral, no, stenosis. Mitral stenosis can cause right-sided heart failure through all this process. But what they're saying here is you can't call right-sided heart failure cor pulmonale when they have a reason it's mitral stenosis. That's not cor pulmonale. Cor pulmonale is the actual lung tissue or the lung vasculature that causes the problem. Acute issues of cor pulmonale, massive pulmonary embolisms, or injury due to mechanical ventilation, most commonly ARDS. ARDS is acute respiratory distress syndrome. You can't support your own airway, you have to be intubated. So that's what ARDS is. These are acute causes of cor pulmonale. Remember, we are dealing with either the vessels or the tissue of the lung itself. We've damaged either of those with the acute causes. The chronic causes, loss of lung tissue due to surgery or trauma. You had a lung resection due to a tumor, so now your lung capacity got reduced. It can cause, relate that into increased pulmonary vasculature pressure related to right-sided heart failure. Chronic unresolved pulmonary emboli, here's your pulmonary hypertension, and then pulmonary interstitial fibrosis. We already learned about that before. It's a restrictive lung disease. That is a chronic cause of cor pulmonale. So, how are they going to present? Dyspnea on exertion, lack of cardiac output going out, they're not going to have the energy. Fatigue, lethargy, chest pain, parasternal lift. Whenever you start seeing lifts, heaves, movement of the apical impulse, think hypertrophy. The heart got bigger and it's shifting all of these things around. So just think about hypertrophy whenever you see parasternal lift, a heave, those things. Pitting peripheral edema, there's your right-sided heart failure. Hepatic congestion, again, right-sided heart failure. It's going to back up in the liver, causing all those hepatic things. You guys see Mr. Beast take that liver shot by Mike Tyson? That was amazing. He sucker punched him too. It was great. He was meant to. It just hit him. Okay, that's cor pulmonalis. Moving on to pulmonary edema now. Pulmonary. Now, we're going to go through a lot of PEs now. PE could be physical exam. It could be pulmonary embolus, pleural effusion, pericardial effusion. So you have to know the context in which you're reading your question before you start writing PE everywhere. Most common complaint, dyspnea. Dyspnea with pulmonary edema may only present with exertion. And in severe cases, they may have edema fluid in their sputum. So if they start spitting up, it's like pink frothy sputum, kind of like bubbly and sudsy. That's surfactant essentially. And it's in the pulmonary fluid and it's coming out in your sputum. What can cause this? These are all the different causes of pulmonary edema. Some of these you've already gone through. Left ventricular heart failure, you can understand why that causes pulmonary edema. Mitral stenosis, so on and so forth. These are all things that can cause pulmonary edema to form. So, the amount of fluid that crosses the epithelium to get into that lung space is determined by the surface area of the capillary bed. Is the vessel wall even permeable to the fluid? And our transmural or driving pressure. That's also the hydrostatic pressure that pushes the fluid out. Factors influencing most clinical presentations of pulmonary edema are cap permeability, alveolar permeability. Here's your hydrostatic pressure, and here's our oncotic pressures again. Okay, they keep coming up, and they will always keep coming up, so remember these things. Hydrostatic is the push, so if you have more hydrostatic pressure, you're pushing the fluid out. The oncotic or colloid pressure is the suck, bringing it back in. If they're within balance, you won't have any edema formation. If they're not, you get edema formation. Now, there are a couple of ways we can damage the lung vasculature and cause more pulmonary edema. So this slide is very important. I would mark this one to know of the four different types. First one up top is our normal situation. We have, so this is normal. We have our hydrostatic pressure and we have our oncotic pressure in the green. So obviously on the arterial end, we remember from physio, on the arterial end, hydrostatic pressure wins to push the fluid in. On the venous side, oncotic pressure wins to pull the fluid back into the capillary. Therefore, you get no buildup of fluid in the interstitial space up here or down there. So in this case, everything's normal. We're okay. There's no pulmonary edema going on in this case. The next case, this is called hydrostatic edema. This is due to increased hydrostatic pressure causing more push of all the fluid out. This is your CHF, and mitral stenosis will cause a hydrostatic pulmonary edema. Makes sense. We get a buildup of blood in the pulmonary system because the left side is not pumping. So it backs up in the blood backs up in the lungs. If blood backs up, hydrostatic pressure increases a lot. So you get pushment of the fluid and you get pulmonary edema forming. Okay, that's hydrostatic edema. Congestive heart failure is the cause, and mitral stenosis. The next one, epithelial damage. So in this case, we really destroyed or hurt the epithelial membrane, and that allows the vessel to become very leaky now. We talk about capillary permeability. So if you talk about epithelial damage, this is irritant gases and near drowning will cause pulmonary edema forming due to epithelial damage. Those are examples of what can cause that type of damage to the lungs. The next one, endothelial damage, causing pulmonary edema, and this is from ARDS when you've been intubated, endotoxemia, or fat embolism. Okay, so stuff on the right kind of explains what's going on the left, but make sure you understand each type of pulmonary edema cause. Hydrostatic, heart failure, mitral stenosis. Epithelial damage, irritant gases, or near drowning. The last one is endothelial damage, ARDS, endotoxemia, and so forth. So these are different ways you to get pulmonary edema. Why is this important to know what's the cause? Treatment. You have to know what caused them to have this issue if you want to be able to treat that issue. So that's why it's important to know the underlying cause. So there's two types of pulmonary edema. Cardiogenic, so the heart is the cause of the pulmonary edema. This is due to net intramural pressure across either due to hydrostatic or oncotic. This is a mechanical process, meaning it's the pressure that's pushing it out. Non-cardiogenic is edema from increased permeability. You've damaged the vessels, so they become very leaky, and that's what causes the pulmonary edema. So it's not cardiac that's causing the damage to the vessels, it's something else, and that's what we learned about before. It's an inflammatory process, irritant gases, drowning, ARDS. Okay, these things are non-cardiogenic causes of pulmonary edema. Again, caused by left ventricular failure, CHF, orthopnea, paroxysmal nocturnal dyspnea, may have a third heart sound, often found on chest x-ray. I think I have a chest x-ray for you. Tachypnea, as lung compliance goes down, you can't breathe as well, so you have shallow respirations to minimize the work of breathing. So if you take big breaths in and out, there's a lot of work involved for that, but if you reduce your breathing, make it shallow, you don't have to work as hard. And then diaphoresis, they may break out sweats. Cyanosis from hypoxemia, they don't have enough oxygen in the blood, so you get cyanosis. Pink sputum, if you see pink sputum, it's a capillary hemorrhage. It's pink because the capillary broke and you get a little bit of blood in there as well. And pink frothy sputum, capillary hemorrhage, pulmonary edema. Usually due to what? What would cause a capillary to break? Usually pressure. High pressure will make those capillaries burst and you get that stuff. Inspiratory crackles, wheezing, and rhonchi. So all these weird things on inspiration only, not expiration. Non-cardiogenic pulmonary edema, what causes these things? Sepsis, high-grade bacteremia. They'll appear stable while the capillaries get damaged. Surfactant is inactivated. So as lungs are the little alveoli start to collapse on themselves because the surfactant is not working as well. If you reduce the amount of working alveoli All the other alveoli have to work harder, and it causes issues. Dyspnea, tachycardia, alveolar edema. Mechanical ventilation is usually required for these patients, and they have a high mortality. Most, again, due to the presenting illness. The mortality is not due to the pulmonary edema. The pulmonary edema is a consequence of the underlying disease. So that is what's going to kill them, not necessarily the pulmonary edema. Okay, pulmonary effusion. Okay, so that was edema. That was in the alveolar space. Now we're talking about a pulmonary effusion. This is excess fluid in the pleural cavity between the lung tissue and the pleura that surrounds it. Just like we talked about the pericardial effusion, that little thin space, fluid gets in there. Same thing here. Fluid gets into that pleural space. Production exceeds absorption, and you get a lot of fluid there. 90% of a transudative pleural effusion is CHF. We talked about transudate and exudates before. What's the key difference between the two? Protein. Okay. Transudates, again, indicate the absence of pleural disease, so treatment is the underlying cause, so the prescription, whatever. So transudative, mainly water, hydrostatic pressure goes up, pushes it out into the pleural effusion, pleural cavity, so on and so forth. If they have an exudative pleural effusion, think cancer. An exudative pleural effusion, think cancer. Also can be caused by pneumonia or infection, but the majority of them are due to cancer. So if you ever see anything with exudative pleural effusion, think cancer at first. Again, exudate has the proteins. Transudate does not. Okay? Those are the big changes. One has protein, one doesn't. What we got left? Okay. What time do we start again? Like 2:10, right? Okay, we'll finish up in a minute. I'll finish up whatever we have left tomorrow. Etiology of these pulmonary effusions, obviously CHF is going to be the number one. Hypoalbuminemia, because that decreases oncotic pressure. So when you decrease oncotic pressure, which one wins out, the push or the suck? Push, so you push more out, more pulmonary effusion. Atelectasis, decrease in pressure in pleural spaces. So atelectasis is a little collapse of all the little lungs. The little airways, alveoli clusters, they collapse. Less area for gas exchange, less pleural space. Pneumonia can cause it as well. Any impaired drainage, so malignancy, if you can't drain out of it, like the lymph tissue can't drain it, then it builds up in that area, causing the effusion. Movement of fluid from the abdomen, so cirrhosis can also cause pulmonary effusion. And an extravascular source, so a fistula. Here is what you'll see though. Because the fluid is in between the lung and the pleura, you get little meniscus of fluid values, the little levels. So one of the big things you'll see with a pleural effusion is called blunting of your costophrenic angle. This is your costophrenic angle. But now it got blunted because all of that is filled with water or exudate or transudate, whatever it is. Whatever the effusion fluid is, it fills up and it works its way up. The worse the pulmonary effusion, you can have a line all the way up there, and that's all fluid on one lung. So you lose your costophrenic angles. Yep, so here's a picture. Okay, you don't see that nice angle there. It's been obliterated because you have all fluid working its way up. And you can see kind of where it stops. Okay? All that stuff on the bases, that's the pleural effusion. If it gets worse, you can do a thoracentesis. You put a needle into the pleural space and you suck out all that fluid. And then you can test it to see what it is. So that is what pleural effusion looks like on a chest x-ray. You blunt the costophrenic angles. They're gone because it's filled with fluid. Examples of different effusions. You can have what's called a hydrothorax. Hydro basically is like water. This is your CHF fluid. You can have a pyothorax, pyogenic infection. These are usually due to penetrating wounds or some sort of bacterial pneumonia. But again, pyogenic, they start, a lot of these weird pus will get in there. Empyema is the pus. The pyothorax will just cause you to get sicker. Empyema, thick pus accumulating. Hemothorax is blood. Chylothorax is lipid-rich fluid due to a lymphatic obstruction. So a chylothorax is also, if you can call it fat effusion, because it's just fat that gets in there, lipid-rich stuff. And then here's your slide again, looking at transudates versus exudates. So make sure you know the causes for each and the big thing, which is the protein and the LDH. Low with transudates, high. Everything's high in exudates, low in transudates. Light's criteria is a formula that you can use to determine, is this exudative or is it a transudative effusion? I'm not going to have you calculate Light's criteria. You all have phones. You'll have calculators on your phones. What you have to know is that, hey, if this person has a pulmonary effusion, I know Light's criteria is the one that I need. Now I can look it up and figure it out. I'm not going to have you do all this, but just understand Light's criteria is the one that's mainly used to determine if this is a exudate or a transudate. However, what are they really looking at? Protein and the LDH ratios, which I've already told you what they are here. You don't have to do them again, but just know Light's criteria is what you do for that. And how much slides do I have left? So I have like 20. Okay, we'll finish this tomorrow and then we'll do a review. We got plenty of time. Yeah.